privileged to be here today and welcome you to today's online presentation, an update on the Canadian Longitudinal Study on Aging, or CLSA, for participants across Atlantic Canada. Before we start, I just want to confirm, maybe Gervais, if you could give me a thumbs up that everybody can hear me. Okay, awesome. Thank you. All right, let's get started. We're so happy to have you here today. We're going to start with a land acknowledgement because the CLSA is located on lands that are home to many diverse Indigenous nations. And we really respect the treaties that were made on these territories and acknowledge the harms and mistakes of the past as we dedicate ourselves to moving forward in partnership with Indigenous peoples and communities in a spirit of reconciliation and collaboration. Before we get started, I just have a few housekeeping notes. So everyone but the presenters will be muted throughout the webinar. If you need to change or test your audio during the webinar, you can click Audio Settings on the bottom of your Zoom window. Today's presentation is being recorded and live streamed on YouTube. Closed captions are turned on. To change your caption settings, select Captions at the bottom of the Zoom window. If you have any questions or comments, you can type them into the Q&A box at the bottom of your Zoom window. However, please note that questions submitted in advance will be prioritized. If you have any technical issues, please use the chat box to inform our communications team and they'll do their best to help you out. And also a feedback survey will be launched at the end of the webinar and we invite you to complete it after exiting the Zoom session. This brief survey provides us with important feedback that we can use to plan our future webinars and participant events. So our agenda for today will include an update on the CLSA, followed by 3 presentations that highlight key CLSA findings and impacts from the study. As much as possible, our speakers have tried to incorporate the questions you submitted during registration into their presentations so that we make sure we're answering as much as we can from you. But we had our work cut out for us. There were more than 250 questions submitted in advance. Thank you so much for your participation in this way. We really love hearing from you and understanding and being able to give back some of the information you're looking for. We'll do our very best to answer as many as we can during the Q&A period that will follow the formal presentations. So briefly, we're going to do a welcome and introductions and quick update by me. We'll talk quickly about study enhancements and data linkage, have a couple of presentations, and then I will do the Q&A and closing for you. It's now my pleasure to introduce our presenters. Besides myself, today's presenters include Dr. Gervais Gao. He is the St. John Site Principal Investigator and a new Associate Professor of Clinical Epidemiology at the Memorial University of Newfoundland. Dr. Gao's research includes epidemiology and genetic epidemiology of respiratory diseases, using large population-based data sets to study the environmental exposures and genetic risk factors for respiratory dysfunction and diseases. Dr. Esme Fuller-Thompson is a professor and director of the Institute for Life Course and Aging at the University of Toronto. She's cross-appointed to the faculties of social work, medicine, and nursing. Her research has been widely cited in the media, including the New York Times, Forbes, Time Magazine, Toronto Star, and the CBC, and her recent publications using the CLSA are in immigrant health and depression during the pandemic. Ujikwu Adimba is currently pursuing a PhD in clinical epidemiology at Memorial University in Newfoundland. We're so happy to have a trainee here with us. His research focuses on the epidemiologic and genetic determinants of chronic respiratory diseases. He uses large data sets like the CLSA to investigate environmental and genetic risk factors which influence disease development and progression. His broader research interests include chronic disease multimorbidity, population health, and the application of advanced analytic methods in population health research. Welcome to all of our presenters. So to begin, I'm just going to give you a brief update and sort of overview of the CLSA. So I'd like to highlight first our scientific leadership, including the principal investigators, Parminder Raina and Christina Wolfson, and principal investigator emerita, Susan Kirkland. Also pictured here are co-principal investigators and associate scientific director. Dr. Theo and Cook Hubley will be joining us today as panelists as well. And these are our site principal and co-principal investigators across Canada, and we're so happy to be able to collaborate with all of them to bring the CLSA to you. Each of the CLSA sites also employs dedicated staff who facilitate the collection of data directly from our participants across Canada. And these are some of the familiar faces who you might remember interact with in person or over the phone when you connect with the CLSA. So today we're pleased to welcome staff members from Halifax and St. John's data collection, as well as the Halifax Caddy site and the National Coordinating Center in Hamilton. So if you guys want to turn on your cameras and give a little wave, that would be great. We're so happy to have all of you here, and we know our participants really enjoy interacting with you, so thanks for coming. Particularly, please join me in welcoming coordinators Katarina McIntyre from Halifax and Aliona Lewis from St. John's and William Martin from the Halifax Caddy site. We're also pleased to welcome additional staff members, Stephen Cook from St. John's DCS and Ashley Ann from the Halifax DCS, as well as Amber Johnson from the Halifax Caddy site. From the National Coordinating Center in Hamilton, we welcome Cassia, Markar Daron, and from our participant management team, please feel free to wave and say hello now. For any of you who haven't already, we're happy to have you here. Oops. Okay, so just a quick history of the CLSA. CHR put out a request for applications for an aging study back in 2001. And it actually took 10 years to develop the protocol that turned into the CLSA. So that was 10 years of working out all the ethics, all of the consent, all of the questions we're going to ask you. And recruitment finally began in 2010. And baseline data collection began in 2011. From there, we've followed participants every 3 years, and we're now on follow-up 4. And I think this really represents a unique funding system in Canada. There are very few other studies that have been sustainably funded the way that CLSA has and been able to collect data over such a long period of time. So we're very, very lucky. We also marked 10 years of data collection in 2021 and 10 years since the first data release in 2025. So what is the CLSA? I'm sure you're all very familiar at this point for your 4th follow-up, but the CLSA is a comprehensive research platform designed to support population research into healthy aging and lead better quality of life and health for Canadians. It's the largest and most comprehensive platform on aging in Canada and is considered one of the largest internationally for its breadth and depth of data collection. So this is an incredibly unique resource, and it is thanks to you all. And the CLSA couldn't exist without our large network of collaborating institutions from across the country. This does really represent intense collaboration across all provinces, institutions, and funders. We have 10 data collection sites across Canada, indicated by the green dots here, and we collect telephone interviews from participants from all 10 provinces. So the CLSA research platform enrolled 51,338 participants who were aged 45 to 85 years of recruitment. So this group was composed of the CLSA tracking cohort, or the telephone interviewing, and the comprehensive cohort, or the people who come into our site and have physical measures taken. Within the tracking cohort, there were over 21,000 participants enrolled, and in the comprehensive cohort, there are over 30,000 participants. Data is collected from active participants every 3 years, and baseline occurred between the years of 2012 and 2015, and we do our follow-ups every 3 years after that. Unfortunately, we were briefly interrupted by COVID, but we were able to get back on track. And as you can see in this diagram, we anticipate follow-up 6 will be the final data collection ending in 2033. So overall, the data collection spans 20 years, and data and sample will be kept for another 25 years for research. This is an incredibly long-standing and unique impact that your participation has. So we just cannot thank you enough for supporting aging research and now research and training for future generations. So listed here are the many types of data that the CLSA collects, many of which you may be familiar with. And we can go into more detail with some of them, but the overall picture is that the CLSA collects detailed, thorough, and ongoing data that paints a picture of the health of Canadians as they age through many spheres of well-being, including physical, mental, social, emotional, and biological health. The data we collect has evolved over the years, but as technology has shifted and new information has become available, but how do we collect this data? If you're a member of the tracking or comprehensive cohort, you're asked to answer a variety of questions on physical, social, and psychological health. These questions largely remain the same over time, but new content has also been added. We do want to keep it the same over time so that we can look at changes. But as technology becomes available or there are new issues that arise, we start collecting new data as we can for each wave. As many of you have experienced, if you attend data collection site visits, there are a number of data collection measures completed there. Some things include physical assessments, height, weight, BMI, bone density, aortic calcification, blood pressure, ECG. There's all kinds of measurements. And there are cognitive measurements as well, looking at memory, thinking, executive function, and reaction time. And lastly, there is biospecimen collection, which includes blood and urine samples. So as you can see, this is very comprehensive. It's a lot of work for our participants, so we are eternally grateful for their participation and dedication. Some of you may wonder about losses of participants and data as the study goes on. This typically happens with every cohort study that we lose some people every wave to follow up. And what we found is by the end of the second follow-up, 7.4% of participants had withdrawn from active data collection, though most of these, almost 80%, continued to agree to have their data linked to health records. So about 7% of participants have died since their baseline assessment. We do have strategies to help prevent losses and keep people in the study if they would like to stay involved. And this includes a web questionnaire for participants who move out of the area, as well as designating proxies for the participants who can answer questions on their behalf if they're no longer able to. So importantly, and probably of most interest to all of you today, how are the data that are being collected being used? So your participation is critical, and we understand it can be more difficult as we age. And with each passing follow-up, the data collected becomes even more valuable as it paints a more fulsome picture of health through aging. So we really appreciate the efforts you've already made, and we're moved by your continued dedication to the CLSA and to aging research in general and making a difference in your community. Your participation is truly making a difference every day. So let's go through some of the impacts the CLSA has had on the aging research landscape. And again, none of this would be possible without you, so thank you so much. So there have been more than 800 approved research teams since 2014, and many of these are led by trainees, which is really, really incredible to see the next generation of researchers being able to use this really important data. Most of these projects are based in Canada, but there have been international projects across the globe that have used our incredible data. And there have been over 500 publications published in scientific journals with groundbreaking results on healthy aging. These approved projects publish their findings in peer-reviewed scientific journals, like we said, over the 500. Since the CLSA began, we've published these articles, but they've also increased in frequency through the years. So more and more people are accessing and using these data and finding results that are increasing the impact of the data collection that we have. You can see a selection of the publications here on the screen, including some from the presenters of today's webinar. So topics span a range of things, including nutrition risk, social participation, successful aging and frailty, retirement, and cognition. And these are just a few examples of the recent publications using the CLSA data. And we encourage you to use the link provided to look up findings on any topic you might be interested in and see what the CLSA has done in that area. As well, publications from the CLSA data are sometimes covered by the media. So CLSA data has been shared with media sources that include newspapers, online news sources, radio, TV interviews, and more. And they've been covered by big media like CBC, CNN, Newsweek, US News, and even internationally. You can find recent examples of media coverage in the news tab on our website. And the links to the article shared here will be shared in the chat box. But this can give you a quick update on what's been found in the CLSA recently. If you happen to be wondering, check out the website. So projects and publications using the CLSA data have also had an impact on policy. So as you can see here, this impact includes the Public Health Agency of Canada using the data from our research study, the COVID-19 Immunity Task Force, and the World Health Organization Decade of Healthy Aging Baseline Report. Examples of these will all be listed in the chat box as well. Essentially, the graph here shows that with each passing year, the CLSA has been mentioned and cited in more and more policy documents. This is a representation of how CLSA data is helping to shape the way agencies in Canada and internationally are addressing how people age on topics like COVID-19, elder abuse, and more. The impact of CLSA would not be possible without your continued participation. So now that we've touched on some of the ways that the CLSA data is being used to make a difference, I'm going to hand the presentation over to my colleague, Dr. Gervais Gao, site co-investigator for the Memorial Data Collection Site in Newfoundland, to discuss some new developments in the study. I'm going to mute myself, and Gervais, you can take over.
Can you hear me? Can you hear me?
Yes, I can hear you.
Excellent. Thank you.
Thank you.
Thank you, Lindsay. Hello, everyone. My name is Gervais. I'm happy to be here to discuss some new developments in the study. Next slide, please. On this tree, you can see how the CLSA has grown and developed to collect more and different data since the beginning. I will be detailing some of these key enhancements today. Some of these initiatives are ongoing as we proceed with the data collection through follow-up 4. Next slide, please. So follow-up 4 is a very exciting time. I'm excited for participants and for all the data that's going to be collected. Some of the new measures in follow-up 4 are eligible to all participants. So both comprehensive and tracking participants. Next slide. Those include additional questions on ageism, experience, as well as cannabis use. There are also new measurements that are eligible for comprehensive participants, which will be conducted at data collection sites. These include measuring smell, using what is called a sniffing sticks, as well as vision. Our staff in the DCS are well trained in these new measures, so there should be no crossover and exciting new data collected. Next slide. When you are completing your visits at the DCS, you might notice some changes between follow-up 3 and follow-up 4. For example, in a follow-up 3, heart function was measured using ultrasound on the neck to assess the thickness of the artery. In follow-up 4, heart function is going to be measured using cardiac ultrasound, also known as an echocardiogram, to examine the structure and the function of the of the heart. Next slide, please. Devices used to track mobility begin to be used in follow-up 3. These include a TicWatch, as well as Actigraph, which are worn on the thigh. These devices track activity and community mobility, for example, driving, and the span of active environment. The opportunity to use these measures is available for all comprehensive participants. Next slide. Additional sleep trackers have been introduced. So as you can see in this photo, this includes a Muse headband and an Actigraph, which in this case is worn on the wrist. These devices track sleep quality and a pattern of sleep. Eligible participants will include 2,360 comprehensive participants. Next slide, please. In the questions we collected for the study, Many of you asked what some of the findings that the CLSA has produced. Before I get into some of the exciting new major enhancements to the CLSA, I want to share some information from initiatives that have been completed. Next slide. CLSA memory study was completed between 2022 and 2024. This was a $1 million study funded through the PHAC. It investigates whether information collected through CLSA interviews can be used to correctly identify individuals who have memory problems and individuals without memory problems. 597 CLSA participants with a range of cognitive abilities completed a medical assessment and neurocognitive examinations, and also identify a family members or friend for a 2-minute telephone interview. The data analysis is currently underway for this study. Next slide, please. There were 3 studies that emerged from the COVID-19 pandemic, launched April 15, 2022. The CLSA COVID-19 questionnaire study collected data from 28,559 CLSA participants. The study collected the data from participants on a weekly, biweekly, and a monthly basis to understand the epidemiology of COVID-19 among older adults living in Canada. These data collected included information on COVID-19 symptoms and status, risk factors, healthcare use, health behaviors, psychosocial and economic consequences of the pandemic. You can access our dashboard of the results on the CLSA website or by using the link in the chat. Between November 2020 and July 21st, the CLSA COVID-19 seroprevalence study, also known as the CLSA COVID-19 antibody study, collected and analyzed the blood samples from CLSA participants in 10 provinces to test for the presence of antibodies that indicates infection due to SARS-CoV-2 virus and/or vaccination. You can download the results from this study at the link that is pasted in the chat box. The COVID-19 brain health study was launched in the summer of 2021. The data collection continued until the beginning of 2025. Data was collected through a phone assessment and MRI. The COVID-19 brain health study is a sub-study of the CLSA, inviting eligible participants to take part by completing a phone interview regarding their cognition, feelings, and lifestyle. It also involves having MRIs done at a local clinic. Next slide, please. There have been many remarkable findings that have occurred out of COVID research. I am just going to touch on a few here. Pandemic depression persists among adults who are lonely. Those findings came out in 2021. Female caregivers who provide intensive care at home experienced high levels of depression and anxiety during the pandemic, March 2022. Hard to change minds when it comes to vaccination willingness. That study came out in April 2022. For people over 50, even mild COVID can result in mobility problems. January 2022, pandemic prompts higher intake of flu vaccines among older adults, January 2022. And 1 out of 4 older adults experienced changing in their alcohol intake during the pandemic. More information on this publication and the findings can be found on CLSA COVID-19 data dashboard linked in the chat. Next slide, please. And now, on some of the new ongoing initiatives that CLSA is currently collecting data for. Next slide, please. CLSA Healthy Brain Healthy Aging Initiative. The CLSA Healthy Brain Healthy Aging Initiative launched in September 2022. This is a $12 million brain health initiative, was funded by the Western Family Foundation It involves 6,000 comprehensive participants who provide a stool sample and include MRIs for 2,630 of these participants. They are also asked to wear mobility trackers for 7 days to enable continuous measurements of the physical activities. The introduction of the CLSA Western HBHA initiative provides a unique opportunity to assess research on the aging brain from a multi-system approach that requires data from cell to society. Next, please. Your stool sample provides an entire ecosystem of information. Trillions of microorganisms inhabiting your gut constitute a biological fingerprint that can inform us about your diet, environment, and general health throughout life. Your gut microbiome is in constant communication with your brain and the central nervous system, vice versa. This bidirectional crosstalk is integral to every aspect of human health, from cognition, immune functions, metabolism, and hormone production. Your gut microbiome changes as you grow up and as you age. This is totally normal, but how these changes differ between individuals can impact their quality of life and longevity. We know that microbiome has a causative role in aging. When we plant microbes from young animals into older ones, it counteracts age-associated brain inflammation, immune decline, frailty, and behavioral issue. Part of the goal in the CLSA cohort is to identify microbial markers of healthy aging and integrate that information with a functional measure of cognition, metabolic health, and immune function. This multimodal signature will help us to identify mechanisms by which gut-brain signaling influences age-related decline. Next slide, please. One of the most exciting new updates on the CLSA is collaboration between the CLSA and the Human and Health Data Research Network. From the very beginning, the goal of the CLSA has been to look at the change in health over time and to get the best understanding possible of the aging process. With that goal in mind, the CLSA was designed with the intention to link data that was collected with data held in provincial and national dataset. A collaboration between Canadian Longitudinal Study on Aging and Health Data Research Network Canada is allowing researchers access to linked CLSA cohort data at the provincial health administrative data centers across the country to explore the intersection between aging and healthcare utilization. This linkage allows for the pairing of complementary information on health services use with the in-depth information collected by the CLSA. But what is administrative health data? Next slide, please. Administrative health data is routinely collected as a part of a normal operation of the health system. Nearly every interaction that a patient has with the health system produces some type of a record that can be used anonymously for research purposes. This can include physician visits, hospital admission, emergency room visits, and home care, assuming it has been public funded. Administrative data is very advantageous as it contains accurate health system data on nearly everyone in a province. However, it can be challenging to use because it is not collected for research purposes, and sometimes important pieces of data that researchers would like to have are not available. Next slide, please. Any identified information, for example, age, date of birth, address, home card, health card number, is held and shared separately to enable the linkage of the CLSA participant's unique ID with the individual's provincial ID. Once this is done, the study information is assigned to a unique common ID that allows them to be linked without the use of identifiers. Researchers can then submit proposal to access the identified linked data to answer groundbreaking research questions about health and aging. These requests must be approved by both provincial data centers and the CLSA. Researchers may request linked data in a single province or in multiple jurisdictions. Next slide, please. We have linked CLSA data in 4 provinces: BC, Ontario, New Brunswick, and Nova Scotia. We are very close to finalize the data sharing agreement necessary to link the data in Quebec and Newfoundland and Labrador. We are currently negotiating agreements to link CLSA data in Alberta, Saskatchewan, and Manitoba. This work has been done in collaboration with the Health Data Research Network Canada, their data access support hub, and a provincial and a national data center member. To date, 6 projects have been submitted and approved. Example of the data linkage and how it can be used. CLSA information is linked with the physician billing information and the seniors medication insurance program information to understand the diagnosis and medication prescribed for certain conditions. CLSA information is linked to health services use and hospital discharge information to understand risk factor for certain conditions and the causes of the death. Next slide, please. The CLSA interviewed Dr. Aaron Jones, assistant professor at McMaster University, about his study linking CLSA and the provincial data center to examine the role of home care payment source on health service outcomes in Ontario. This team seeks to understand how many CLSA participants are accessing public and/or private home care, and to describe the differences between the group. We would also like to understand how the use of a public and a private home care influence future healthcare uses, such as hospital admission, emergency department visits, and admission to long-term care homes. The study benefits from using linked CLSA data with provincial administrative health data because administrative health datasets have excellent records on publicly funded healthcare use, but don't have any data on home care that was privately purchased. By linking data from CLSA to health administrative data, this study combines one of the only sources of data on private home care use in Canada to comprehensive gold standard data on health system outcomes. Studies like this that utilize linked data can inform funding for home care and shed light on capacity and funding challenges. This provides support for an informed future in the sector. Next slide, please. When participants first provide consent to participate in the CLSA, you were asked to give permission to provide your health card numbers to facilitate the linkage. The CLSA is committed to protecting the privacy of participants, safeguarding the confidentiality of personal information, and ensuring a secure environment for all information collected as a part of the CLSA research platform. Thank you. Without your consent, we would not be able to do the work that we do. That being said, we respect the decision to withdraw that consent, which you may do at any time. Those who have withdrawn consent to linkage are not included in the data linked at the provincial data center If you would like to discuss your consent to linkage, please contact info@clsa.elcv.ca. Next slide, please. Simply, why is the data linkage collaboration such an important development for the CLSA? Linked data increases the number and the depth of a potential research question that could be answered exponentially. It also allows researchers for insights that would not be possible without CLSA study data alone or with the provincial data alone. These data sets are so much more valuable together than they were on their own. And importantly, consenting to data linkage supports your already valuable investment in the CLSA through your participation to go so much further. Again, thank you for your commitment to this study. Next slide. It cannot be overstated how grateful we are at the CLSA to all participants for your continued engagement and participation. As the study progresses, your contributions become more and more valuable to the aging research sphere. The CLSA boasts the highest participant retention of all comparable studies globally. That is directly due to the commitment of each participant and each one of you. Your participants leave a legacy for your family and the future generations of research that is already spanning the globe and asking deep, meaningful questions about what it means to age well. Thank you. I will now pass the presentation to Dr. Fuller Thompson, who will be presenting her own CLSA-based research.
Thank you so much. Okay, from the beginning. So thank you so much for the opportunity to speak. I love talking to people to whom I am indebted, and that would be you. So the topic is Nourish to Flourish, exploring the links between diet, mental health, and verbal fluency. But let's see, page down. But an alternative title would have been What We Have Learned Thanks to You. We could not do it without you, absolutely. I first want to thank all of my co-authors, a lovely team. I call it the dream team. It's been so wonderful. We've been working together since 2017, and a variety of colleagues and graduate students, several of whom have gone on and are now professors. But my main thanks goes to my colleague and co-author, Karen Davison. Karen is a nutritional epidemiologist and was really instrumental in helping us interpret this data and think this through. Our starting point was that there's a rising epidemic of mental health problems in Canada and in other high-income countries, and we really don't know why. And my starting point, even though I'm a gerontologist and I work primarily with older adults and older adult research, this actually started in my classroom. I've had the privilege of teaching at the University of Toronto's Faculty of Social Work for 30 years now. And when I first started teaching, there were very few people who were struggling with mental health, serious mental health issues that needed accommodations in class. And by the late teens, this is even before COVID, I was getting 5 to 7 students out of every 25 who were struggling with mental health issues. And also, I have young adult children, millennials, and Gen Zers, and their peers are really suffering. So I'm sure many of you have children and young adult children and or grandchildren, and have seen this wave of anxiety and depression that is really concerning. So we had this hunch that we know that good nutrition is essential for physical health. But could nutrition also be important for mental health? So basically, your brain is just your body above your neck, and we know that that nutrition is very important. So, is there a rise in mental health problems linked to this, an increase in ultra processed food and a lack of quality nutrition? So, that is what we're hoping to be able to look at eventually. Right now, we're just asking the first question, which is, well, what does the literature say? And it didn't actually say very much. There wasn't a huge amount of literature looking at nutrition and mental health. So we needed to find a large Canadian data set with excellent measures of both food intake and mental health. And the solution was you and the CLSA. It's a wonderful data set which had all this information in it. We had a second hunch, which is we know that what's good for the heart is good for the brain. So the question is better nutrition associated with cognitive assessment called better verbal fluency? So in summary, what did we find? So this is, I mean, I have to tell you, what we found isn't too much like what your mother and your grandmother told you, but we found it statistically, and hopefully that'll influence people's practice. But we looked at inadequate fruit and vegetable consumption of less than 3 per day. I mean, ideally, you want at least 5 or more. So we found it was associated with depression, with anxiety, with post-traumatic stress disorder, and with lower verbal fluency. So those are 4 different papers, but I'm just giving you the take home, which is, uh-oh, you need to eat your fruits and vegetables. But the question is, fruit and vegetables, it's hard to keep it all primed. I'm just seeing if I can close this down because, all right. But what about if we just have orange juice? So, you know, that's a fruit, even pure orange juice. But it turns out pure fruit juice every day was associated with a higher prevalence, not a lower prevalence of depression among women. And there was no association with anxiety or post-traumatic stress disorder. So fruit juice is not going to do it. And in fact, may be potentially harmful with respect to depression. Much better just eat your fruit. It should have the fiber with it. Now, those who consumed fish were less likely to have depression, anxiety, post-traumatic stress disorder. So if, you know, consuming fish weekly seems to be very positive. Eating nuts and pulses. So by pulses, we mean like lentils, chickpeas. That's associated with a lower risk of depression, anxiety, and higher verbal fluency. Now, obesity was not a good thing. Again, these are things your mom and grandmom told you, but obesity, which is based on self-reported height and weight, and they use that to create something called the body mass index. Sometimes it's called BMI, but basically, obesity is associated with a higher prevalence of depression, of anxiety, of post-traumatic stress disorder, and lower verbal fluency. But it's not, there's a sweet spot. So it turns out being underweight is as bad as being obese with respect to your risk for depression, anxiety, post-traumatic stress disorder, and verbal fluency. So you really want to be in that normal weight rather than too high or too low. So there was questions about nutritional risks, things like skipping meals and eating alone, and that was associated with depression, post-traumatic stress disorder, and lower verbal fluency. Now, consuming chocolate bars, which is like that's my nemesis, it was associated with a higher levels of depression and PTSD, like worse outcomes, but better verbal fluency. We're not quite sure what's going on there. I wouldn't say that the take-home message from this is go buy your Lindt chocolate and down it. Certainly, it's not that. But it was interesting to see that association. So we need to explore that further. But we have all these limitations. These are just what we call associations. They're not necessarily causal. It's not as though we can say consuming pulses causes lower depression. What we really need is randomized controlled trials to do that. That means when you take a group of people that are basically similar and then you randomize them, one gets the lentils every day or 5 times a week, and one doesn't, and then we follow them to see how their depression. That would be a randomized controlled trial. We're not doing that. The first step is there an association? And that's what we were able to establish with this range of studies that we've done in the last 7 or 8 years. But that was just using your baseline data. Now we're going to look forward to saying, are those who've had mental health problems at the beginning, are they more likely to recover from, say, depression or anxiety by the follow-up ways if they had better nutrition at baseline? Does better nutrition help build them back up? That's question one for longitudinal. Question two is, those who are free of mental health problems at baseline, if they had good nutrition, are they less likely to develop mental illness or cognitive problems in the future? That includes when there was a huge traumatic world event, such as a pandemic that hit us all hard. Were they more likely to be resilient in the context of that? I also wanted to share some really helpful resources, or what I hope are really helpful resources. It's my privilege to run the Institute for Life Course and Aging at the University of Toronto. And we have a whole series of videos on modifiable risk factors for dementia. It turns out that about 40% of the risk of dementia are things that are modifiable, that things that you can change. They're not your genes, they're not getting older. Those things you can't change, obviously, but they're more like nutrition is one of the major ones, but there's also several others. So when I just finish this slide, I will present just 1 minute video to give you an idea of what they look like. And then we have these easily digestible evidence-based videos on each of these topics in both French and English. It was funded by the Public Health Agency of Canada. We also have a series of short videos with experts on how to manage sleep problems, memory loss, anxiety, depression, caregiver stress. So I believe they'll put links to those, and we really love for you to use these free resources and also to share them with others who might find it helpful. So thank you again for making the CLSA and our research possible. I'm just going to stop sharing, and then Amy's going to share just the 1 minute video for me, please. Oop, I don't hear the sound, Amy. You might have to stop and check that. There's usually a little button which says fix for sound or something like that.
Sorry about that, everyone. I'll just be a second.
Or alternatively, we can put it on during the Q&A if that's easier. If you prefer. Lindsay, would you like to take it over and then we'll do that later, or what would you prefer?
I'm happy to take over, and we can put it up later. I think our next speaker, Ugochukwu, would you like to go ahead and share your screen?
Yes, thank you so much. Can you see my screen?
Yes, we can.
Okay. Good day, everyone. I am Ugochukwu Odimba, a doctoral trainee in clinical epidemiology at Memorial University of Newfoundland. I want to thank Lindsay for the introduction and for passing this presentation baton to me. It's an honor to present the results of our study today, especially to you CLSA participants whose commitment to providing data made this research possible. My presentation today is titled The Prevalence and Risk Factors of Most Common Multimorbidity Among Canadian Adults, Findings from CLSA study. So this study was actually published in PLOS ONE journal in January 2025, and the full article can be accessed by scanning the QR code in this slide. So in order to give this talk, we are going to go through this outline, and I'll first of all introduce multimorbidity and then the purpose for this study. And then we will go over the brief methods applied in our study, and then I will share some of the key insights and the results. And then we look at the potential future studies, and then we conclude using the key takeaways from this very study. So let us begin by defining what multimorbidity is. It is simply the coexistence of two or more chronic diseases conditions in the same individual. The burden of multimorbidity has always been a significant public health concern globally, in that in 2021, the global prevalence was about 37%, with North America having the highest prevalence rate at 43.1%. Traditionally, certain factors are associated with rising multimorbidity, and these factors have been well, documented in the literature. Some of these factors, but not limited to them, are, aging population, increased prevalence of chronic respiratory disease, lack of physical activities, which could lead to sedentary lifestyle, and conditions like being obese or overweight, as well as low socioeconomic status and an individual's genetic predisposition. Is multimorbidity a serious public health challenge? Yes, it is, but how is that the case? It's really a public health challenge because it's been linked to increased mortality, reduced quality of life among sufferers, and definitely impaired functional status. It also leads to increased healthcare utilization and places a substantial burden on our healthcare system. So in the context of Canada as a country, and 1 in 3 Canadians lives with at least one major chronic disease. And the prevalence estimates of multimorbidity in Canada at the moment ranges from 10 to 26%. And this number is expected to rise in the coming years, which is also a source of concern. In fact, a recent cross-sectional study using CLSA data reported a multimorbidity prevalence of 39.6%. Why did we decide to look into the most common multimorbidity? What are our study objectives? First, we needed to identify the most common multimorbidity among middle-aged and older Canadian adults. And we also wanted to estimate the prevalence of this condition. Then we also tried to identify independent risk factors that are associated with the most common multimorbidity among this age group. And then we explore whether sex as a variable influences the relationship between age and the most common multimorbidity. So just a brief overview of how we carried out this particular research study. In order to carry out these investigations, we conducted a cross-sectional analysis using the CLSA baseline comprehensive data. And this cohort consists of over 30,000 community dwelling adults aged 45 to 85 years, who completed, interviews and then provided data through physical measurements, and also provided biospecimens. We looked at a whole range of potential predictor variables. In other words, variables that we felt may be associated with multimorbidity, and some that had been identified in the previous studies in the literature. Some of these variables include social demographic factors like age, sex, education, marital status, an individual's income, living in rural or urban area, and also retirement status. And we also looked at lifestyle, behavior, and physical measures. Most importantly, physical measures such as BMI, which is used to classify an individual's status, obesity status, or weight status. So alcohol use, physical activity, and smoking status. We also looked at the impact of self-reported sleep quality and also self-reported general health. How did we define multimorbidity? And subsequently, how did we define the most common multimorbidity? We defined this outcome as the presence of two or more physician-diagnosed chronic conditions in the same individual. This was determined by a positive response to the test question provided in the survey. Has a doctor ever told you that you have at least two of the 30 chronic conditions? By 30 chronic conditions, I mean self-reported physician-diagnosed conditions that were based on commonly reported chronic conditions in multimorbidity studies carried out so far in Canada. And the chronic disease pair with the highest prevalence across the population was then classified as the most common multimorbidity for our study cohort. So here is a list of, to give you an idea, here is a list of the 30 chronic conditions we considered, and it ranges from cardiovascular diseases to neurological diseases, gastrointestinal conditions, and chronic respiratory diseases, musculoskeletal diseases, and diseases that affect both the kidney and urinary system. And we also had access to autoimmune diseases, metabolic diseases like diabetes, some certain psychiatric outcomes like anxiety, depression, and cancer. So post-statistical analysis, which we are purely based on one descriptive analysis and the other one analytical analysis, our study revealed that the most common multimorbidity is the coexistence of osteoarthritis and hypertension. And the prevalence of this condition in the cohort was about 16.5%. We also try to summarize the characteristics of our study, of the study participants in this study, and we found that the average age was about 59 years, and 52% of the participants were female. Approximately 70% were overweight or obese, which is really a concern, and 45% were retired or partly retired, with 56% having positive smoking history, and about 65% of those participants did not engage in physical activity. What did we find out? What are those key independent risk factors for osteoarthritis and hypertension as a most common multimorbidity? We actually found out that increasing age, female sex, high BMI, poor perceived general health, being retired, poor sleep quality, and residing in the Atlantic province were significantly associated with higher odds or risk of osteoarthritis and hypertension. So we will dive in deeper and look at the magnitude of these associations in the next slide. So for age, we found out that for each additional year of age, the odds of osteoarthritis and hypertension increased by 10%, and that females were 66% at higher odds of having osteoarthritis and hypertension compared to males. For individuals with high BMI, that is obese individuals, they were 6 times more likely to have osteoarthritis and hypertension, and those who were overweight were 2 times more likely to develop this condition. Self-reported general health gave us an insight. It tells us that individuals who perceived their general health as had approximately 7-fold higher odds of having osteoarthritis or developing osteoarthritis and hypertension compared to those reporting excellent health. So this is really a very strong predictor. So for the retirement status, we identified that individuals who were retired had about 41% higher odds of being diagnosed of osteoarthritis and hypertension compared to those who were not retired, and that self-reported sleep, those who were dissatisfied with their sleep quality had about 31% higher likelihood of osteoarthritis and hypertension. So interestingly, when we looked at geographical patterns, and we also identified that residents of Atlantic provinces, especially Nova Scotia and Newfoundland, most especially Newfoundland and Labrador, had 35 higher odds of osteoarthritis and hypertension compared to those living in British Columbia. Similar trend was also observed amongst the residents of Ontario and Quebec, who had about 26% higher odds of developing this particular disease condition as a pair. For the interaction between sex and age, what we try to do here is to find out how sex influences the association between increasing age and osteoarthritis and hypertension. So we found that sex significantly modified the association. And what does that tell us? It tells us that the odds of osteoarthritis and hypertension associated with increasing age was significantly higher in females than in males. And the proportion was about 12% per additional year of age in females and 8% per additional year of age in males. So this indicates that females aged 45 years or older are much more susceptible to osteoarthritis and hypertension associated with increasing age. So this is purely, a snapshot analysis and a cross-sectional analysis. So in other words, we cannot infer causality. So we still need future studies, to explore this little groundwork that we have done. So we need longitudinal studies to determine whether osteoarthritis and hypertension still remain the most common multimorbidity among middle-aged and older Canadian adults, and also to identify and confirm some of the associated risk factors that we have so far identified. Because we found a significant sex by age interaction, it tells us that there might be sex-specific differences, in the development of this particular outcome, osteoarthritis and hypertension. So it's also important for us to consider sex-specific studies that we identify if genetic markers or biological markers or biomarkers, lifestyle or behavioral factors that may contribute to why women experience a greater age-related increase in osteoarthritis and hypertension. So what is the key information? What is our take home here? So we concluded from our data that osteoarthritis and hypertension is the most common multimorbidity among Canadian adults aged 45 and older, with a prevalence of 16.5%. And that we also identified certain primary modifiable risk factors, including being obese and overweight, a poorer rating of perceived health, and poor sleep quality. These are modifiable factors that can be changed for improved health amongst our aging population. Also, in addition to some of these modifiable risk factors, we also found that increasing age, sex, and living in the Atlantic province was also factors that are associated. Were also factors that were associated with most common multimorbidity among middle age and older adults in Canada. So females aged 45 and older were much more susceptible to this condition associated with increasing age. So these findings clearly highlight the urgent need for us to think about prevention strategies tailored towards targeting modifiable risk factors, and for us to also think about regional specific planning to support older adults with complex health needs. I want to thank everyone for listening to this presentation, most especially the CLSA participants who made this research work possible. Thank you.
Thank you so much, Ugochukwu. That was wonderful, and thanks for spotlighting your work as a trainee as part of the CLSA. We're so happy to have you here. So that concludes our formal presentations. So now I'd like to open it up to questions. I will just share my screen here so you have some info on how to ask your question. Just give me 1 minute. Okay, so just a reminder, the muting will remain on, but you can enter your questions into the Q&A box at the bottom of the Zoom window. Many of you submitted questions during registration, so thank you so much. We've read all of them. There were very many, and I'm so glad to see you guys so engaged. We as panelists will answer a few of the most common ones that we got, but please feel free to add in the Q&A. I'll just make sure I can see it here. Yes. So one of the first questions we got was, what are the most important practices for seniors that positively impact healthy aging? So I'm happy to answer this, but also we can open this up to the panelists. Does anyone feel like they really want to answer this one?
I'd love to jump in, and it's a great segue after this to show about cognitive well-being, because the little video kind of covers some of those things. But there are so many things that are within our control to some extent. Things like not smoking. It's never too late to stop smoking. You get benefits within days and weeks and months of stopping smoking. So that's a good start. Social interaction that I think we're going to talk about a little bit more, but isolation is really problematic. Nutrition, which is kind of my little bit that I'm on right now, and sleeping well. Those are just some of the things I wanted to throw in. But maybe, Amy, would you be able to show the video about cognitive health, which kind of goes, basically your brain and your body and your heart all connect, and what's good for the brain is good for the heart. So, Amy, is it possible to show that?
Yep. I'll just be
Great.
1 second.
Awesome. Just while we're waiting for Amy here, I just want to remind everyone as well that all of the links that we shared in the chat, as well as the recording for this webinar, will be emailed out to you probably in the next week or so. So don't worry, when you close the Zoom window, all of that has been captured and we will send it to you.
Well, yeah, okay, great.
Dementia is not an inevitable part of aging. Find out how we can help our brains continue to function well as we age. Recent research has suggested that we can lower our risk of developing dementia by 40%. We can have a healthier brain and reduce our risk of dementia if we stay physically active, stay mentally active, get at least 7 hours of sleep a night, stay socially connected, eat healthy food, maintain a healthy weight, manage our stress levels, quit smoking, don't drink too much alcohol, manage our blood pressure and diabetes, get our hearing tested, get help when feeling depressed. Visit the link below to learn more about how to decrease our risk of developing dementia.
Thanks so much. So what I wanted to just emphasize is those are all the things you need to do to stay healthy, not just healthy brain, but healthy body. Absolutely control your physical health. Visit your doctor to keep that under control. Sleep well, keep mentally stimulated. All of those things are basics, but pretty important basics.
Thanks, Dr. Fuller Thompson. Just echoing that, I think sometimes we want a silver bullet, and really all of these things that we're talking about are unsurprising to probably most of you, to like exercise, eat healthy, take care of your sleep and your chronic conditions. But these are the building blocks that help you throughout life and into later adulthood. And it is never too late. Improving those things where you're at can help at any age. So I think that's really a hopeful message in some way, that you can always sort of do your best to take that on at the place that you are, and it will be helpful.
Yeah, maybe I can add a couple of things. You see, for World CLSA, we we have so many new things, and we try to measure, let's see, all those tracks and mobility. What's the reason why we want to measure that one? Because there is a scientific evidence showing that mobility can have an influence on or basically or aging or healthy aging. And also the reason why we say, okay, we want to measure how the sleep quality and the sleep patterns using all those active graphs, and those actually have an impact. There is a reason why CLSA, we start to get more and more technologies and all try to add all those measurements, new developments. There is a reason. Actually, this is actually the aspect if you as an individual, we can improve.
Yeah, that's great. Thank you, Dr. Gao. I
I
think
just wanted to jump in. So exercise is good in and of itself, and you might be social while you're exercising, so you can, go for a walk with a friend, so you get the social support and exercise. But also, one of the important things to do as you age is to prevent injuries. And falls are one of the major parts of injuries. A broken hip really throws a hammer in all the works of well-being. It's really difficult to come back, though people can come back, obviously. But the stronger you are, the more your core strength, the stabler you are. That exercise gives you that. And and nutrition, of course, also helps with, protein and etc. But if you can work on keeping your strength, and you can come back from feeling a little bit unstable. I have a 91-year-old friend who had been falling in her early 80s and then started to go to a gym, and she's actually got better posture and more strength than I do right now. So you can come back. So.
I absolutely agree. And some of the most, I guess, emerging research is showing, I guess, the thread of social connection through all of these risks or protective factors. So actually exercising in a social setting is better for you than exercising alone, whether that be because it keeps you coming back or it just adds that cognitive and social stimulation to it. Again, with diet, eating together as a family or as a group is better for you than eating alone. So really weaving that social piece in. That's true for cognition as well. Some of the biggest boosts to cognition are not necessarily through apps or games or specific things that you need to do, but it's through socializing, talking to other people, being cognitively stimulated by your environment in general. Anybody else want to add anything, or should we move on to the next question? Ready to move on? All right. One thing that a lot of you have questions about is whether we can be given the results of your tests, and how much information is available to you as participants. So you do own your own data, and you can call the helpline to get individual results. We do not give out results to participants at the time of collection because a lot of these data are essentially not meant for clinical interpretation. They are for research only, and they require some processing or interpretation to be useful clinically or sometimes to be redone. So what we do is any of your data that is collected is flagged if there is an abnormal or incidental finding, and we communicate that with you and give you that information that you can then take to your doctor. But as part of the confidentiality and consent process, we are not allowed to give any third party, including your doctor, your data. We have to give it directly to you. And then you can pass that on as you wish for the most part. Yeah, in the case of incidental findings, we do communicate that with you directly, but otherwise you would need to contact us to get any more data that you might want. Jennifer, did you want to jump in on that at all? Is there anything I forgot or you'd like to add?
Or I have to unmute all the time. No, I think I think you've captured it.
Okay. We know, obviously, as participants, this is, you give us an incredible wealth of data, and obviously you deserve everything that we can give back to you. Again, the reason we don't do that is it's not particularly useful information without any kind of interpretation or processing. We are very appreciative of you sharing that data with us, and we will obviously do whatever we can to keep you healthy and safe. If there's something we note abnormally on any of your data, we will let you know. But yeah, we can't share personal results otherwise with other people. Okay, is there any other responses to that from the PIs, or are we good to move on? Okay. So something else that was asked was what has been learned about aging and social connections or the social determinants of health? Is there one of the panelists that would like to address that specifically? I know we've been sort of talking about social connections in general. Dr. Fuller-Thompson?
Yeah, I'm happy to jump in on that one. Social connections are everything for humans. It's so important. So there's been some research suggesting social isolation, which is, not having social connections, not having a BFF, a best friend, or really socially removed from your community, is associated with as great a risk for premature death as smoking 15 cigarettes. So we all know smoking 15 cigarettes is not a good thing for your health, but social isolation and severe loneliness are a problem. Now we're living in a post-COVID world, and it's harder to make connections, but there are opportunities within communities for volunteering, for reaching out. Even if you have mobility issues, there's other people that could, make a friendly phone call, check in. So there are some resources in different communities that could make a difference. And sometimes even connections, small connections like talking to the cashier, if you're, can make a bit of a difference. So as I see with my mom who's in her 90s, the trouble is her peer group, many of them are not with us anymore. And so that those intergenerational connections, some of which she started when she was in her 60s and her girlfriends were in their 40s, are paying off big time now. But it's never too late to start making connections across the generations. It's obviously easier if you have children and grandchildren in the area, but even if you don't, there's lots of opportunities to connect with others. And I highly recommend thinking about that. Social connections are just so key to who we are and so important. And unfortunately, with all the screen time, it may feel like a social connection, but it doesn't resonate the same as having 1,000 people on a screen isn't quite as good as going out to coffee with a friend.
Definitely agree on that one. And it is hard in our evolving landscape. Dr. Gao?
Yeah, I do have some comments regarding social connections, and also the social connections can influence basically. I'm a researcher and in the field of biology or genetic, and also have a very strong impact on basically how your body function, and have an impact on your inflammation. Basically, chronic. We know as you're aging, basically a lot of chronic diseases, the underlying is a chronic inflammation. So the social connection, positive social connection, and also try to stay yourself away from all those negative connection. Be careful. You have to be smart when you choose the social connection. Choose the good one, the positive one, and have a strong biological. There is a scientific evidence showing that a positive social connection have a positive impact on your biological response from your body. And also you have a sleep quality as well, and the cardiovascular events, diabetes, and everything, and including your mental health, how your brain function. And all those things have a very strong, solid scientific evidence. Thank you.
And I realize I probably misspoke a little bit. I'm not saying that having a Zoom call with friends is not good. It's wonderful. I'm talking about screen time when you're just lurking in the background and not really connecting with people. That's not getting you that connection feeling. But obviously, particularly if mobility is an issue or your loved ones and friends are far away, having this type of conversation back and forth, but with a Zoom call or a telephone call, that's also very helpful. Staying connected, but heart to heart connected, not just zooming through notices of their perfect holiday.
Thank you both so much. One other question that we got a few times, which I found really interesting and something I thought we should address, was whether we track the cause of death in our participants and then link that to healthy aging data that we're collecting. And I think that's a really important point because that's in a lot of ways, not just death, but other measures of mortality and morbidity tell us what leads to certain health outcomes. And so the best way that we can do that is through the linked data with administrative data. So that's HDNS, like we were talking about. So when you agree to link your administrative data, we are able to then connect without identifying you, your data collected by the CLSA, and then your medical outcomes, including your cause of death. So we can tell on a population level what I guess variables or factors are determining who dies when. Are they dying earlier? Are they having more complications? This type of thing. The other way that we do that is through a decedent questionnaire. So participants who pass away during the course of the study, we reach out to their next of kin if they've identified someone, like a family member, and we ask them questions about details of the death so that we can collect that data and have on a population level, we can look at the relationships between various data that we collect during life and how people died. So I think that's really important, and we really appreciate the ability to link that data so that we can make these really, really important findings and sort of double down on the impact of the study. Does anyone else have anything they want to add on that? No? Okay. A few more questions that came up were around women's health and menopause. Do any of our panelists want to answer what we collect or what we're doing with that type of data? Ready? Dr. Fuller, I'm sorry, I can't quite see, but did you put your hand?
No, I'm not a menopause researcher. Dr. Gillian Einstein, one of my colleagues, has been looking at women's health in later life, and she'd be able to answer. Women are more at risk for dementia, and she thinks some of it may be linked to menopausal issues, but I can't really speak to that. Though, when we get to the nutrition questions, I'll jump in. How about that?
Sure, yeah, absolutely. Yeah, I think in terms of women's, go ahead, Dr. Gao.
Yeah, I do. I was involved. I did some kind of the research related with menopause, but so basically, because I'm in the genetic component, in the genetic areas, we do find in terms of the biology, we do have a lots of estrogen receptors. So, for example, and at different level. But we all know at the DNA level, and everything basically was over a human, everything is controlled by the DNA. And there are lots of actually is along the pathway, and there are lots of estrogen receptor. So, for example, one of my area is related with asthma COPD, and when you exposed to some kind of air pollution or bacteria and so on and so forth, how does your body respond to such a stimulate or invaders? Actually depends on do you have the estrogen receptor or not. So at the biological level, the pathway, we do have lots of estrogen receptors. That's why, because gender and sex means a biological effect is so important, so crucial when we do a lot of study in terms of the lung disease, in terms of cardiovascular disease, or even mental health. So estrogen receptor, male and female, such a big role.
Absolutely. Thanks for sharing that, Dr. Gao. My research is on generally frailty and dementia, and we do see a survival benefit in women. So women are living longer, but are more likely to be frail at any age. And so I think we've added questions on women's health to the CLSA throughout our follow-ups. And I think having that wealth of information really allows us to dig into the sex and gender differences that we're seeing and not make assumptions about women's health based on what we know about men's health, which has been done in science for a very long time. So I think that's what I have to add on that. We have time for probably one more, maybe a couple more, maybe one more question. Dr. Fuller-Thompson, is there one on nutrition there that you would like to answer specifically?
Okay, so there's a question from right near the beginning from Brent. Thank you for putting it in. About is there a stronger association for a combination of both obesity and inactivity and depression? And yes, it is stronger. I'm not sure if it's additive, like you just add the risk, or if it's multiplicative. It is a higher risk for sure to have both. And it's a little hard to understand what's going on because is it that being inactive makes you more socially isolated and depressed, and that is more likely to increase your risk of obesity? Or is it possibly that obesity makes it harder to be inactive? So it could be some cluster of going on, but we do know that a combination of obesity and inactivity increases inflammation, and it's harder to control your diabetes. So if you have diabetes and you go for a walk after dinner, that actually is really helpful. It doesn't even have to be a long walk, but just to have some activity kind of pulls your blood sugars down. So having that diabetes worse makes you more depressed. So there's something about inflammation, but there's also this physical inactivity can make you feel kind of depressed, and it makes you less socially connected. And, so there's a back and forth with it. So yes, together is not great. Our particular research, we didn't actually combine them, and that would have been a great idea. It's always lovely to think about that. So in the future, I'm going to look at, is it cumulative? Like, does it just, this increases at 20%, this increases at 30%, so together they're 50%, or is it more like 20 times 30, which is sort of 60, 70, 80%? My inclinations, it might be the latter. It might be exponentially, well, not exponentially, but dramatically increasing, but I can't tell you exactly with my own study because I didn't think about doing that, but I will.
That's why these kind of webinars are so important. It gives us
Absolutely.
the participants, and hearing what's important to you guys is really important to inform our research as well. So we love the questions. Thank you to all of our presenters and for the participants for their questions. I just have a couple reminders before we go. Just give me 1 second here. So if you have any questions, please contact us by email. So that is info@clsa.elcv.ca or through our helpline. The phone number for that's 1-866-999-8303. Again, these will be emailed to you. If your contact information has changed, for example, you've moved, gotten an email address, or changed phone numbers, it's really important to let us know so we can continue to be in contact with you, particularly in the way that you prefer. Please connect using the email or phone number listed or by visiting our website, especially if you're interested in latest news or publications or impact coming out of CLSA. We have a news tab that you can take a peek at there. We also have social media, so you can follow us there to see the latest and greatest of what we're up to. And please complete your feedback survey, which will appear when you exit the webinar. Let us know what you enjoyed about the webinar, and we'll be happy to take that into consideration as we plan the next one. Today's presentation is the third in a series of participant engagement presentations. So you're welcome to learn more about these other presentations on our website and the link shared in the chat. There you will also find the slides and the video recording from all of the participant presentations, including today's webinar. And all registered participants will also receive the email I mentioned, alerting them when the recording is available and with the links that we shared from today's study. or today's webinar. Okay. So finally, I'd just like to thank all of the funding agencies, particularly the Canadian Institutes of Health Research, or CHR, and other provincial governments and universities as well. This is really crucial to the work that we do, and being able to fund a study that's over 20 years is really incredible internationally, and it contributes to this wealth of data so that we can make the type of impact that we do. So that's really important. But most of all, we'd like to thank you for your time. We are nothing without our participants. So thank you for all the time and effort and dedication you have to the study, and for attending this webinar. We hope you learned something and you found it valuable, and we hope you all have a lovely afternoon. So thank you so much.
Bye, everyone.
Bye-bye.
Thanks so much. Bye, everyone.
Thank you. Bye,
Thank you.
everyone.
Now.